pain physicians to present cases in pain medicine, and we have a panel of experts to discuss it and give you a solution. So today's experts are going to be Dr. Muralidhar Joshi, the senior most person in the country in terms of pain. Most of
you
us
mean to say old man? It's okay, so fine. Hi, Kumar. Hey, Karthik, go ahead.
President of ISA, Secretary of ISSP. We all know the wonderful job he did when he was in ISSP. He turned the society around. Author of pain books, and I can't enumerate the number of achievements he has had. MD from PGI, and he's a stalwart in pain. So on behalf of all of us, thank you for accepting the invitation and welcome, Joshi sir. And other than Murli sir, we have Devjyoti Datta, Dr. Matthew Tong, Dr. Asha Barge, Dr. Archana Nankar, Dr. Gaurav Sharma, Dr. Shirish, and Dr. G.K. Kumar. So I think Dr. Gaurav, Dr. G.K. Kumar, and Dr. Shirish are joining us newly. Most of the others we have been familiar with in the case discussion. So welcome to all of you. So today's discussion is going to be on facial pains. So we have two speakers today, young upcoming pain physicians who are doing their fellowships right now, who are training in pain. So the first speaker is Dr. Basavaraj Kanti. So Dr. Basavaraj, if you're there and if you want to share your slide, please go ahead.
Yes, sir.
So Dr. Basavaraj Kanti is a diploma in anesthesia from KLE Hospital, Belgaum, Karnataka. He did his DNB in anesthesia in Tata Memorial Hospital, Jamshedpur. Presently, he's a one-year fellow in Daradia. So on to you, Dr. Basavaraj Kanti.
Thank you, sir. So my slide is visible?
Yes.
Okay. Good evening, everyone. I'm Dr. Basavaraj Kanti, the fellow at Daradia Pain Hospital. Today, I'll be presenting a case of 66-year-old male presented with chief complaints of pain in left side of the face since 12 years. History of presenting illness. The patient complained of pain over the skin of the cheek, the upper lip, lateral aspect of the nose, lower lip, and chin area. Pain is characterized as an electric shock-like, sharp shooting, piercing type. Each episode comes and goes suddenly and lasts for seconds to 2 minutes, with 10 to 15 attacks per day with a pain-free interval in between. The pain is moderate in intensity.
Change the slides. Basavaraj, please change the slide.
Go to full screen and you have to change the slides and go a little slow, Dr. Basavaraj.
Yes, this side. One second.
Your title slide is there, but next slide, 2 or 3 numbers you can.
It is not working. Can you present from my laptop? What happened? Okay, from here.
Yeah, can you go to full screen, please? Can you see a 69 at the bottom right side?
Slides here.
Okay, go ahead. Go ahead. It's okay. Go ahead and start.
It's not changing. Okay, make me host. I will present from. No, till Karthik sir from here.
Dr. Basuraj, please go ahead. We can see the screen. Don't worry about it. Please go ahead.
Okay, sir. So I am presenting a case of 66-year-old male presented with chief complaints of pain in left side of the face since 12 years. History of presenting illness. The patient complaint of pain over the skin of the cheek, the upper lip, and the lateral aspect of the nose, lower lip, and chin area. Pain is characterized as an electric shock like sharp shooting, unbearable, piercing type.
Are you able to change the slides, please? No?
Sir, I'm changing slides, sir. Is it visible?
Not really. It's just your history of presenting illness.
Dr. Basuraj, click on the next one, third slide. Dr. Basuraj, click on the third slide on to your left.
From beginning. Stops here.
On your left. That will do. Don't worry about it. Don't worry extra things.
Screen.
And that's better.
Yeah, go ahead.
Yeah, that's better. That's better. You can just carry that. That's for more than enough noise.
Madahra ini. Ando to.
Okay, Dr. Basavaraj, go ahead. If you want, I'll share the slides from my end. Can you? Shall I?
Better, Karthik. You start doing it. Karthik, you start doing it.
Can you see the slides?
Yes, Karthik. Please go ahead.
Okay, yes. Dr. Basavaraj, I have the slides for you. Go ahead. Let me tell me when to change it. I'm sharing the slides for you.
It's fine, Karthik. Let's go ahead.
I can control your slides, Dr. Basavaraj. Please go ahead.
Karthik, go to the third side. Go to third. Yeah, yes. Yeah.
Okay, sir. Pain is moderate to severe in intensity with NRS of 6/10, and it's aggravated on chewing, talking, brushing teeth, and washing face. Patient feels slightly better after sleep and medications. No history of redness or watering of eye, no history of pain near eye, upper cheek region, no history of swelling of eyelids, and no history of nasal discharge or congestion. Past history, there was history of tooth extraction, molar teeth of upper and lower jaw 11 years back. Treatment history, the patient underwent radiofrequency ablation of Gasserian ganglion 3 times, and he also had a history of Stevens-Johnson syndrome with carbamazepine 12 years back. Now the patient is on tablet pregabalin 75 mg plus nortriptyline 10 mg TID and tablet baclofen 10 mg TID. Personal history, diet is mixed, appetite normal, sleep sometimes disturbed due to pain, bladder and bowel habits are regular. Coming to general physical examination, here is a 66-year-old male patient, moderately built and nourished, conscious, oriented to time, place, and person. BMI is within normal limits, pulse rate is 70 beats per minute regular, blood pressure is 128/76 mm of Hg. Psychosocial history, he experiences fatigue, occasionally wakes in night, severe pain episodes impact daily activities. There is no anxiety or depression when the pain is controlled. Coming to examination, inspection, the skin is normal. There is no wasting of muscles or obvious deformity. No swelling, scars or ulcers. Jaw movement capacity is within normal range. Coming to palpation, the range of motion is normal. There is no temporomandibular joint or masticatory muscle pain on palpation. Coming to neurological examination, olfactory nerve, normal smell sensation, optic nerve, the pupil size, shape, symmetry is normal, visual acuity is normal. Oculomotor, trochlear and abducens nerve, ocular movements are normal, pupillary light reflex is normal. Coming to trigeminal nerve, there is allodynia over lower jaw and cheek region. Forehead sensation is normal. The muscles of mastication, motor power is adequate. Corneal reflex and jaw jerk is normal. The facial nerve, the facial movements are normal. Then vestibulocochlear, hearing and balance is normal. Coming to glossopharyngeal and vagus nerve, the gag reflex is normal. Lavacranial nerve, shrugging of the shoulder is normal, turning of head from side to side is normal, and hypoglossal nerve, the tongue movements are normal. Investigations, complete blood count, ESR, CRP and LFT were within normal limits. MRI brain was normal. There was no vascular loop around the root entries. What is the diagnosis? Thank you.
Okay, thank you, Dr. Basavaraj. So essentially, we are looking at a 66-year-old male patient with left-sided facial pain. The regions that Dr. Basavaraj has mentioned look like they are mainly in the V1, V2 and V3 dermatome. Am I right? V2 and V3, is that right?
Yes, sir.
So V2 and V3 distribution pain, 66-year-old male, left side, 12-year history. Patient is not tolerating carbamazepine. Patient developed Stevens-Johnson syndrome to carbamazepine. 3 times radiofrequency ablation done. Can I ask you, when was the last RF ablation?
Sir, it was done 2 years back, sir.
And so after RF ablation, his pain has recurred. Is that what you're saying? After
Sorry,
the
I could not hear you.
after the RF ablation, his pain has recurred, is it?
Yes, sir. I mean, he came to us last week, sir, with complaints of pain or infraorbital region and mental nerve region, sir.
Okay, okay. So can I call on the experts now? First, can I invite Muralidhar Joshi, sir, to ask him, patient 66-year-old male, left-sided cheek pain, V2, V3 distribution, 3 times RF ablation done, and he's having a recurrence now. Sir, at this point of time, what should we consider? What should we think about?
Karthik, as per the literature and all, it's they say as per literature, it is said actually the medication can work for 6 to 8 years. But of course, I had some patients who say that they're happy for nearly 17, 18 years also. Like textbook is one thing, but normal medication is supposed to work for 6 to 8 years. But 12 years, definitely something has to be done at this point of time. Some of these patients might go to what is called trigeminal neuropathy, because question here is the ganglion itself might have been completely 3 times due to the RF blazing, it might be destroyed, like it might be firing on its own. But one more thing I would like to say at this stage is, for example, it's only one side, not a problem. But I think, well, medication-wise, for example, you see, you cannot keep on doing the RF. And of course, even if you look at the MRI and all those things, only 30% of patients will get some vascular conflict, what you call neurovascular conflict and all. I think I would have gone for a MRA, not MRI, MRA brain to rule out another possibility. There could be multiple sclerosis, 63-year-old you're saying, or maybe neurovascular conflict can pick them much more better than a plain MRI brain. And one more thing is, you want to have pharmacologically also, like, I don't know, carbamazepine, I think he had Stevens-Johnson. Maybe I have tried phenytoin. Phenytoin action release. I'm getting very good result these days with many of the refractory patients. But the question here, you have to investigate in case something else is there, you can work on that. But I think MRI brain will be good because 3 times you have tried, you've done your best, nothing wrong about it. But I think MRI brain will be ideal at this stage. That's my take, Karthik, at this stage. Maybe others have the better opinions. I wait for the rest.
Thank you, sir. So what sir is saying is, one possibility is trigeminal neuropathy, which can happen after a few episodes of successful RF ablation. That is one possibility. Second is he wants to know there is a secondary cause for trigeminal, things like a multiple sclerosis. So he wants to investigate this patient further. Point taken, sir. Now I'm going to go back to Dr. Basavaraj and ask him, was a MRI or an MR angiogram done for this patient? Dr. Basavaraj. Unmute yourself.
Sir, MRI was done, sir. It was done during that time only. The recent MRI was not done, sir. MRI was not done.
And did the MRI show
Karthik, MRI is different, MRA is different. Is what
Correct,
I want to discuss.
So what was done and what was found, Dr. Basavaraj?
Sir, MRI was done, sir. There was no there was no lesion in the intravascular lesion, sir, and there was no vascular loop around the root entry zone, sir. There was no mass lesions.
There was no possibility, or at least at the point of initial diagnosis, you are saying secondary causes of trigeminal have been ruled out to a certain extent.
Yes, sir.
So what he is saying is this is a trigeminal neuralgia without any superior cerebellar artery compressing the fifth cranial nerve root entry zone, and basic stuff like multiple sclerosis have been ruled out.
Yes.
Right. At this point of time,
Karthik, one more thing also, like there could be spinoparietal issue also. Let's not forget that one. Spinoparietal issue also can be there. Because you are talking of V2, V3, there is an element for V2. When you ask for investigation, what the readership says, correlate clinically. Clinically, if you suspect, like I suspect this one 3 times has been done, it could be spinoparietal ganglion overactivity rather than the trigeminal. We might be at a wrong spot also. Possibility is probably investigation-wise, we should be liberal at this time because everything has been done. MRA is one thing, and spinoparietal ganglion also, like just said, make out, but of course, diagnostic block for spinoparietal will not cost you anything, and of course, will not lose anything.
Right, sir. Right. Point taken, sir. So at this point of time, can I invite Dr. G.K. Kumar and ask him?
Yeah, sure.
Left-sided facial pain, trigeminal is one of the things that we are thinking about. Kumar, sir, what else should we think about in terms of differential diagnosis? Kumar, sir, you have to unmute yourself.
Yeah. Can you hear me?
Yes, sir. Go ahead.
Yeah, this is the case of nice presentations. The case is also very interesting that we have to take the point is the clinical presentations more or look like a typical presentation of the terminal neuralgia. The patient may develop due to the neuropathy, as Karthik also pointed out. But this is the case, we have to take it as a repetitive postally responsive pharmacological therapy. So it is the case of, again, we have to move around the differential diagnosis of the typical atypical facial pains may be in background, but most of the clinical conditions are, as he pointed out, there was nothing there typical supportive of the atypical facial pain. As he not ruling out.
I think Dr. Kumar's internet is not great. Dr. Gaurav, can I invite you now and ask you, in terms of differential diagnosis, we talked about trigeminal neuropathy. What else should we think about?
Yes, already Dr. Joshi has given the differential diagnosis of trigeminal neuropathy. Then we can think about sphenopalatine neuralgia because character is more towards the neuralgia other than neuropathy, but we have to rule out the things. Then slightly allodynia features are there, but other sympathetic involvement and all these things are not there. But we have to rule out the sympathetic involvement of the dermatomes over there. Then multiple sclerosis already we have ruled out initially. Then that TMJ is also ruled out by the examination and all other parts. Then there's a terminal branch neuropathy can be there individually, like infraorbital or mental, or these are the common things. Initial presentation of the patient when the patient come for the first procedure or the second procedure, and now the presentation can be slightly different. So we have to check whether the terminal branch is involved or the whole V2 or V3 is involved. So you can sort it out for peripheral procedures. So these are also the point we should taken care. And then one sometimes myofascial and migraine, vascular migraine, these are commonly, but all other features are negative towards them. So more importantly, we can say we have to rule out the sympathetic involvement, trigeminal neuropathy, then sphenopalatine neuralgia according to the condition, and the peripheral nerve, you can say infraorbital as well as the mental neuralgia. So these are the possible differential diagnosis according to the examination and the history.
Thank you, Gaurav. So essentially what the experts are saying are, at this point of time, the differential diagnosis that we should keep is trigeminal neuropathy. It could be sphenopalatine neuralgia, dental origin pains, including TM joint, root canals. Those things we have to keep in mind. We don't have the latest MRI, but the old MRI at the time of initial diagnosis rules out any other intracranial pathology. We have not done an MR angiogram to rule out AV malformations and thrombosis and more detailed examination, but a basic MRI we have done. And it doesn't seems to be having any other feature suggestive of sympathetic. Now, at this point of time, if I can invite Dr. Archana and ask her, any other differential diagnosis? Can this be a cluster headache? Can this be a atypical facial pain? Anything else, Dr. Archana?
Yes, sir. So actually, they have taken a very good history. So in cluster headache or other types of trigeminal autonomic cephalgias, there will be autonomic symptoms related to the pain. So there will be watering of eyes, ptosis, meiosis, congestion of the conjunctiva. And the duration of attack will be also longer. In case of cluster headache, 15 minutes to 180 minutes. So in the history, they have ruled out mostly the if it can be trigeminal autonomic cephalgia. Plus atypical facial pain, it could be a possibility. But I think atypical facial pain is more constant background pain is there. It means it won't attack in it won't occur in paroxysms. That's what I feel. Yes.
Okay. And right now, can I ask Dr. Asha, is there now that we have about 5-6 differential diagnoses, is there a possibility that we have missed something else? Could this be something like I think somebody has pointed out in the chat box also, could this be a temporal arthritis? Is there any other possibility in terms of differential diagnosis? Dr. Asha? Not
I
able to
think
hear you.
it can be, see, even if it is there, you can always do a diagnostic block and try it out. You don't, the question here is we are trying to rule out whether if the MRA is, we're not missing out any AV malformation or CP angle tumor or small visiting or metal scale. But having said that, there could be peripheral reason also for some of these things and all. But let's not forget 3 times RF has been done. Hopefully, qualified people we can understand about that. But it can still happen because only one more thing we have to understand is any procedure you do, that you do an RF lesioning, you do cryo, you do, for example, the balloon this thing inflation, or you want to do a cyber knife, or you want to do the like a Genetous procedure with respect to water micro decompression. The recurrence rate is 25% at the end of 1 year. Let's start from there. The recurrence rate, as per the literature of any of these 8 procedures, is 25%. But having said that, even if thrice we had done RF lesioning, also it's our responsibility. You know, whosoever has done with respect to the people in the, we had to look into that one. Are we missing something, or is something else? Or also the one thing is sometimes when you ask for investigation, it takes some time for the investigation to come, patients to come for follow-up and all. That's why I'm looking at it like, you know, which medication you might be used on Steven Johnson syndrome. Like, you know, to go for investigation, we have to give some pain relief till the reports come back.
Right.
Also equally important, Karthik, because report might come, yes, even if a report comes something, they may not have enough money to go for something else. So these are the things that pharmacologically, if we are not explored about, that's one more thing very important. That's my suggestion, Karthik. Please go ahead. Please go ahead.
Thank you, sir. Can I ask Dr. Shirish now? Any other investigation you want at this point of time, Dr. Shirish?
With regards to the history taken by Dr. I think this much and also discussed by our expert panelists. I think with his history and his examination, most of the features are going towards the trigeminal neuralgia. I think this much of investigation is well and good, but if you are thinking of other like temporal arthritis, a simple CBC count, or even a CBC or even sodium potassium to start off with the drugs, and RFT and LFT will be better. If we are planning to start carbamazepine and go with the diagnosis of with trigeminal neuralgia, at least CBC and sodium potassium has to be baseline, can be done, as the drug itself can cause problem in these aspects. But with history and the probable diagnosis that we have accompanied, this much is, I think, well and good for the trigeminal neuralgia.
Thank you, Dr. Shirish. So what the expert panel essentially is saying is a lot of things are possible, but from the findings that we have and from the history that we have elicited, so the possible diagnosis seems to be more in terms of either a recurrence of the trigeminal neuralgia, which has occurred after a third successful RF ablation, trigeminal neuropathy, or spinopalatine neuralgia. So we have ruled out other things in terms of by MRI and clinical findings. So just for the sake of the juniors, so whenever you're looking at a patient like this, please make sure you're ruling out simple metabolic causes. So whenever you're looking at patients like this, you need to do your complete blood count. You need to do your ESR, CRP, random blood sugar, renal function test, vitamin B12, D3, uric acid, calcium. So these things have to be done mandatorily in all patients. Don't miss out simple things. So you don't want to miss the B12 deficiency, D3 deficiency, increase uric acid. So that has to be done. And ideal situation, you would want a MR angiogram as well. So we have 2 or 3 as a differential diagnosis. We'll see how we go ahead and confirm the diagnosis and offer treatment. At this point of time, can I ask Dr. Archana? He told something about Stevens-Johnson syndrome and carbamazepine. So can you elaborate on that? And should we mandatorily be testing all patients for Stevens-Johnson syndrome, Dr. Archana?
Sir, yes. So carbamazepine is known for this complication, Stevens-Johnson syndrome, that is allergic reaction. Actually, this patient, we can't give carbamazepine, or we can't give oxcarbazepine as well. We have to think of other medications, other anticonvulsants for the medical management. Stevens-Johnson syndrome is like a dermatological emergency, so that's why we have to avoid it. So what was the other question you asked? Sorry.
Do you routinely screen for Stevens-Johnson syndrome in all patients going for carbamazepine?
No, we don't routinely screen for Stevens-Johnson syndrome. We don't.
Right, thank you. So what happens is, I think Dr. Matthew Tong, since you're there, I might ask you about Stevens-Johnson syndrome, and please elaborate about the genotype that you're mentioning. Dr. Matthew Tong.
Hello.
Yeah.
Actually, I have not done it, but I had patients who already had the testing done. And so the neurologists are all doing it in Singapore. So I have encountered Stevens-Johnson's, and it has been lethal in one case I saw. So I think it's expensive, this test, but it is advisable if available.
Yes, I think I share that opinion as well. I've had one patient who had Stevens-Johnson syndrome after carbamazepine. Now, what happened was this patient was on carbamazepine for some period of time. It didn't happen during the first time I gave the medicine. The patient was on carbamazepine for some period of time, like 2-3 months, and then she developed the allergic reaction. So it really put me off. If it had come in the first sitting, it would have alerted me that I've started a new drug. She has developed a reaction. So I would have picked it up earlier. So the patient was on carbamazepine for almost 2 months, and then she developed it. So at this point of time, the consensus is, I think it's going to become a guideline that ideally you want all your patients who are going to be on carbamazepine and oxcarbazine to have the genotype testing. So you have to check for the allele, and then only you are entitled to start carbamazepine. This is the ideal situation. I think it's a matter of time before this comes in the guideline. A lot of neurologists I know actually follow this rule. So this is something that the junior should keep in mind. A lot of patients on carbamazepine, since we start this drug very commonly and we use it in lots and lots of patients, reasonably safe drug, this complication can occur. And it's possible that in the future, you may have a guideline saying that all of these patients should have the genotype that is mentioned, HLA-B 1502 genotype allele testing to confirm that. Okay, so now that we have a differential diagnosis, at this point of time, it is available in India. It is available in India. I know people in CMC do this testing. Dr. Joseph Abraham has asked this question. Yes, it is available in India. It is a matter of time before it's available everywhere. Right. So at this point of time, I would like to go back to Dr. Muralidhar Joshi and ask him, considering our differential diagnosis is a recurrence of trigeminal neuralgia, trigeminal neuropathy, maybe a possibility of spinopalatine neuralgia. We have ruled out other causes by investigation and clinical findings. Is there a role for a diagnostic block in this patient? And if so, which block, sir?
Yeah, Karthik, just only two things, of course. First one, I would like to say about this particular, what is the trigeminal we're talking about with respect to the carbamazepine. It's a good idea and all those things. Because same thing, I'm telling you, there are people who are on clopidogrel who are still having heart attack. Let me start from there. There are people on clopidogrel recommended by cardiologists. They're getting heart attacks. They gave me this kind of enzyme estimation. And they said like everybody we were putting clopidogrel, they should go through this investigation. And it was more of industry driven. So that's one thing, Karthik, I would like to say at this stage. Yes, it's good. But unless we conduct our own trials in India, before we ask everybody who has gone to carbamazepine, the test versus, we have to look at risk benefit ratio. That's fine, Karthik. That's as a moderator, it's your call that you can elaborate. Spinopalatine diagnostic block, I still recommend Karthik. It can be one of the confounding factors in many of these conditions. Nothing wrong about that. We don't lose anything. Diagnostic block, I strongly recommend because everything has to be under imaging guidance. and it will be there, it will be documented. I think it's worth trying, Karthik. Of course, after all the investigation, once the clinician is comfortable, I strongly recommend spinoperatin. If spinoperatin doesn't work also, even if you want to stimulate also, I'm not much worried about that one. But of course, usually spinoperatin works, but sometimes because what happens, all the cerebrosympathetic flow goes from below upwards. So
Okay.
you never know sometimes from the diagnostic. The 3 times you attend RF, either he has to go for surgery or think of something else. Don't see the diagnostic blocks. What do you lose? You don't lose anything. But question here is patients and also the clinician should have the patience to try it out. That's what my thought this is, Karthik. Over to you, Karthik. Thank you.
Thank you, sir. So what sir is saying is at this point of time, one of the diagnostic blocks that we can consider the diagnostic sphenopalatine ganglion on the left side and see if this patient responds, and then we take it from there. At this point of time, I want to go back to Dr. Basavaraj and ask him, you said 3 RF ablations. I want to know roughly how long this patient responded for each of these RF ablations.
Sir, each RF lesion, he had a pain relief for around 1 to 2 years. Sir.
Okay, so the last RF ablation was how long ago?
2 years ago.
Right.
Sir,
okay.
actually, this patient came to hospital in November, sir, last year, and he had pain around the area of inferior infraorbital and mental nerve, sir. So, sir had done cryoneurolysis of infraorbital and mental nerve, sir. He had a good pain relief for 4 months. Now he had come last week only to us with pain with. There was pain relief, some amount of pain relief around the mental area, mental nerve area, but he had some pain in the supply of infraorbital region, sir. So, sir repeated cryoneurolysis of infraorbital region 3 days back.
Right. Okay. At this point, I would like to go to Dr. Gaurav and ask him, considering this history, would you be more comfortable going for the ganglion, or would this preference be going for the peripheral branch? Like, see, if you are having ophthalmic, it's possible that you do the supraorbital. If you are having maxillary, it's possible that you do the infraorbital. Sometimes mandibular can be managed with mental or inferior alveolar nerve. So what is this normal preference? Which would we preferably block, the ganglion or the peripheral nerve, Dr. Gaurav?
In our practice or in my experience, whenever these patient comes with the recurrence of the pain, just you have done 1 or 2 procedures and then the patient come with the problem that I have developed pain again in the corresponding dermatome. So most of the time, the localization is slightly different to the original. So we have to see whether the patient is, the pain is almost similar to the previous one when the patient comes first, or it is a newer pain, or sometimes it cover the whole dermatome, or sometimes it's only cover the terminal branch. As I already told you, some infraorbital or the mental, sometimes it likes. So we have to judge it by the clinical examination, properly asking the right questions. Then we have to discuss the plan of procedure. So if it is more towards the peripheral terminal branches, then we can opt for peripheral RF ablation or the cryo, whatever the things we have. And if we think about that, we have to cover 2 dermatomes, V2 and V3 or V1. So then we can go for the central or the more centrally located lesion. This is how it should progress.
Right. Thanks, Gaurav. So what Dr. Gaurav is saying is, given the fact that when you do the primary procedure, like your first procedure, the blocks done in the ganglion level work a little longer than what is done at the peripheral level, because what happens is the synapse takes place at the level of the ganglion. So if you do an ablation or a neurolysis at the level of the ganglion, it takes more time for the ganglion to regenerate. So since it takes more time for the ganglion to regenerate, it gives more longer analgesia to the patient. But if you see a patient like this, where you've already done the ganglion block, You have to choose depending on the patient situation, whether you're going for the peripheral nerve block or the central nerve block. So I would accept that argument. Thank you, Gaurav. At this point of time, can I invite Dr. Shirish and ask him, considering this situation, do you concur whether we should go for the diagnostic spinopalatine ganglion first on the ipsilateral side as your first diagnostic intervention? Dr. Shirish.
Yes, sir. As like Dr. Muralidhar sir has already stressed out the importance of one of the differential diagnosis of the condition, and since the patient is having a recurrent RF lesioning, requiring a recurrent RF lesion, yes, spinopalatine block can be a very useful tool for the management as well as for the treatment of the condition. So I would, since according to history, like 3 times RF has already been done, so I would like to go for the spinopalatine block.
Right. Thank you. Thank you. Thank you. So, okay. So what we have is the expert all seems to agree that from the history and the differential diagnosis. So this is a patient with symptoms suggestive of V2, V3 neuralgia who has had some success with RF ablation. MRI does not show any neurovascular compression, and repeated RF ablations in the ganglion and at the peripheral level has given the patient a relief of somewhere around 1.5 to 2 years from the history. And this patient is not exactly somebody who is tolerating neuropathic pain medicine, especially we are not able to give carbamazepine or oxcarbazine. At this point of time, most of the experts seems to agree that the diagnostic spinopalatine ganglion is the way to go forward. Now, at this point of time, I would like to ask Muralidhar sir, in terms of pharmacology, is there anything else that we can offer for this patient?
Karthik, there are 2 things I would like to say. For example, we have about 5-6 medications only for neuralgia which are approved. Listed, you got carbamazepine, oxcarbazepine, and you talk of pregabalin, talk of gabapentin, got baclofen, right? Maybe sometimes you may use amitriptyline here and there, nortriptyline here and there. One medication what we are not using, where I'm getting very good result is phenytoin. Phenytoin extend release, not the 100 milligram one. Phenytoin 300 milligrams, single dose in the night. It's making a lot of wonders with these kind of refractory conditions. It makes wonders. It makes wonders. You may not believe. Sometimes you ask for MRI, sometimes patient might take extra time to get the investigation. Maybe he didn't have money or whatever. See, let's understand our own demography, where we work and all. But each molecule, it takes at least 2 weeks for the blood levels to build up and all. And here I found very great results with phenytoin extend release. It's available and not expensive also. One more thing, Karthik, I forgot to alert you is this patient has undergone molar extraction 11 years back, upper and lower molar. There's something called a phantom tooth pain, which I keep handling regularly. Because see, the true kind of like tooth pain you can handle. One is, see, question here is a regular like tooth fall, which happen elderly people that don't create a pain. The problem is severely infected, some tooth impacted there, somebody forcibly extracts, that's called as phantom tooth pain. And in those conditions, you can just infiltrate into the bed of the phantom tooth, wherever it was there. And because it's simply a phantom limb. Phantom limb sensation is different, phantom limb pain is different. So here, I keep encountering a lot of phantom tooth pain, especially infected teeth, which are impacted just like that, and you extract it and all, they come out like this. So in case these things also, like before you think of brain, think of brawn first. Over to you, Karthik. Over to you.
Thank you, sir. So we learned something new today, including myself. Phantom tooth pain.
Hey, don't. No, but it's real. Phantom tooth pain, very real.
Accepted, sir. Accepted. Right.
Karthik,
Thank you,
can
sir.
I add something to?
Yes, Kumar, sir.
Karthik? Yeah. Sorry for my bad internet connection.
No,
I
no,
want
Kumar,
to
Kumar, problem is you are
substantiate
stage
the-
artist. Kumar, you are stage artist, man. You go ahead. We want to hear from you. Please go ahead.
Yeah,
Please
yeah,
go ahead.
yeah. I want to substantiate one of the very good point Joshi sir brought out is the role of phenytoin in the patients have failure to the conventional or not able to continue the conventional drugs, which is the we are also having very good results with the phenytoin, especially in acute neuralgia. The patient suffers with the pain and he cannot proceed even for the investigations and other things. One or two cases I gave a fast phenytoin IV. It is also very much useful because the safety profile is better than with the phenytoin. So fast phenytoin parenteral also 2 to 3 days the patient has to down. The phenytoin at any form, oral or IV phenytoin is also very much useful that the phenytoin role. In this case, in the given case is clearly said there is the clear cut success with the conventional RF. So my suggestion is rather than to after ruling out other causes as Sir said, secondary trigeminal neuralgia and vascular loop with the MRA, we have to stick on to the RF again rather than they looking for other thing also. But the good suggestion is the trial sphenopalatine ganglion may be the choice we are having that. But we have to rule out what are the character of secondary, I mean recurrence character of the trigeminal neuralgia. If it is simply the peripheral nerve level, we can try the peripheral nerve blocks as it may be useful. Otherwise, the same pattern is again recurs. The peripheral nerve blocks level may not be much useful to us. So again, we have to look for the ganglion level or higher level blockade after ruling out the secondary causes. After ruling out the secondary causes.
Thank you, Kumar sir. So point taken. So 2-3 points that they've thrown up. One is phenytoin seems to be having, phenytoin is a standard second line drug for trigeminal neuralgia. So phenytoin is something that the junior should consider along with other neuropathic pain medicine, right? And second is small possibility of phantom tooth pain. Third is the role of diagnostic sphenopalatine ganglion block. So the peripheral nerve blocks, I think from what Basavaraj said, I think Kumar sir, they have already tried once. I think Dr. Das has done a cryoablation of the mental nerve and the infraorbital is what Basavaraj said, I think. Right. So I think most of you agree that the three differential diagnoses that we have and the role for diagnostic sphenopalatine ganglion block. Now, can I ask Dr. Archana how exactly she does the diagnostic sphenopalatine ganglion block and what exactly she would do to confirm the block is working and to know the diagnostic efficacy, Dr. Archana?
Yes, diagnostic sphenopalatine ganglion block, I will do it under fluoroscopy guidance. And the needle approach is from the lateral part of the face towards the pterygopalatine fossa. And initially, I have to confirm the position of the needle by fluoroscopic views as well as by stimulation. So stimulation, I should get it at the base of the nose. That is a accurate means I have reached accurately in the sphenopalatine ganglion region, and then initially give a local anesthetic, that is lignocaine, and see the response of the patient. And if the pain is reduced by more than 50%, 50 to 70%, then go for RF ablation.
Right. Thank you. Now, I would like to, I'm going to go to Basavaraj and ask him how they actually manage this case. But at this point of time, there are a lot of seniors among the audience. I can see Dr. Ashok Jordan here. Other seniors are there. Dr. Matthew Tong is there. Is there anything else that we are missing, or is there any other investigation they would like to do before I go to Dr. Basavaraj? Dr. Jordan or Dr. Matthew Tong, would you like to contribute anything at this point, or anybody in the audience?
Hi, good evening, Dr. Karthik. I think most of the things are discussed. Treatment part is discussed. So other than the sphenopalatine diagnostic and the adding the phenytoin as the good option. And also in the beginning, Dr. Muralidhar has mentioned that if we do the MRI, arterial MRI, if anything is missing, more minutely we can go about it rather than the general MRI of the brain. I think the good suggestion depending upon the financial condition. But before that, it's as patient is already getting relief by the terminal branches cryoneurolysis, I think adding the medication would be the best choice in the given circumstances. Like phenytoin should be tried because he's intolerant to carbamazepine. And simultaneously, sphenopalatine, diagnostic sphenopalatine, as Dr. Archana just mentioned, by that or by through nose, which is the simplest way, I think is the point. And then we can carry forward for the treatment.
Thank you, sir. Dr. Matthew Tong, is there any surgical angle to this? You are the neurosurgeon in the group. Is there any role for anything else? Muted, sir.
Among the procedures that you mentioned, RF ablation, glycerol, compression, SRS, stereotactic radiosurgery, they're all options which give about 2 years, 1 to 2 years relief. And I don't know whether after 3 RF lesions at their gastrin ganglion, is there any role for all the other modalities of treatment at the same junction? So I'm quite fascinated, and I'm learning something today that when you have individual peripheral branches, you can also attack those, and then using a phenytoin. And I suppose now the next thing to go surgically would be to look for a vascular conflict. And vascular conflict, actually, we don't do MRA, we do something known as CISS, which is constructive interference in steady state. There's a special scan in the system of the trigeminal nerve as it goes forwards to the foramen ovale. As it goes forwards, it's in the cerebellopontine angle, and the scan is sagittal to the nerve, and it is not really a angiographic MRI. That one is how I have been using to diagnose vascular conflict. And then just now you all said you have ruled out multiple sclerosis. I suppose multiple sclerosis has to be ruled out with lumbar puncture, isn't it? I would have thought. These are the only things that I can think about. Thanks.
Thank you, Dr. Tong. So, okay, I think most of us agree on the approach forward. Now that everybody's opinion I've got and we have a consensus, can I ask Dr. Basavaraj how they actually went forward? So the expert seems to believe that we have to do a diagnostic sphenopalatine ganglion block, and then depending on the result, we proceed further. If you have a positive result, there's a role for either a standalone sphenopalatine ganglion RF ablation. If you get a diagnostic positive, there may also be a role for combining sphenopalatine ganglion RF ablation along with the repeat trigeminal RF ablation. That's something that personally I would consider. So I would like to ask Basavaraj how they went forward.
So the patient came to us in November again, sir, with pain around the distribution of the infraorbital region, that is the lateral aspect of the nose, upper area, skin over the upper lip, and chin area, sir. And also the pain distribution of the pain was also around the mental nerve area, sir. The skin of the chin and lower lip, sir. So we planned for cryoneurolysis of the infraorbital and mental. Sir, in November, from November till last week, he had a good pain relief, and he had now pain around only infraorbital area distribution. So a repeat cryoneurolysis of infraorbital nerve was done, sir.
Okay, so the way you did it is because of the pain pattern, since the pain is mainly infraorbital, so you did you repeated the infraorbital RF ablation, cryoablation you did.
Yes, sir.
Okay, so that's fair enough. So essentially, the take-home point is, so it's possible that after initial RF ablation, whether it's done at the level of the ganglion or at the level of the periphery, the efficacy of the RF ablation wanes over a period of time. It's possible, I've seen in my own patients, when I do the initial RF, sometimes the first RF works for longer, and then the second and the third one is for much shorter. Well, classically, a lot of times patients, the first RF may work for about 4 years or 3 years, and then gradually it becomes 2 and 1, and sometimes even 6 months. So that's possible. So if the distribution is only along one peripheral nerve, that to the terminal branch, there is a role for repeating the RF ablation or the cryoablation in this case in the peripheral branch. Yes, that's acceptable. If not, in this case, as most of the experts agree, it would have been a good idea, considering this patient is not responding to conservative treatment, to consider a diagnostic left-sided sphenopalatine ganglion block. And if that was positive, when I say positive, more than 50% pain relief, there is a role for sphenopalatine RF ablation, assuming this diagnosis is going more towards a trigeminal neuropathy. There is also a role which probably I would consider where we combine the sphenopalatine and the trigeminal, but of course you can do only the sphenopalatine. Depends on how good the response is to the initial trial sphenopalatine ganglion block. So if conservative works, stick to pharmacology. If conservative is not working, try for the peripheral nerve branch. If peripheral branch is working, stick to that. If not, think of the diagnostic sphenopalatine ganglion block. If it is positive, go for the RF ablation. Is that acceptable to everybody? Is that a Yoshi sir, is this acceptable?
Yeah, Karthik, it's good, but just for the all the beginners and all those things, even if you don't have RF machine. So Karthik is only within and in the sanctity point of view, please don't look at it from a different. Even if you don't have the RF machine and all those things, at the end of the day, any patient who comes with severe pain, as pain patient, our job is to provide pain relief. You may not have the neurologics and you may not have high-end equipment. Please, even if we can't do anything and all those things, because there are some patients who just come with severe pain for some stress and all, can still diagnostic block with respect to the probably the divisional branches and all. But once you hit the ganglion, I started my career starting with peripherally and then wanted to go to center. But it so happened subsequently in the corporate world was a different volume altogether. Then I started hitting the center. From there, after that, I never did many peripheral. But in case if I'm sitting in periphery, if I can go back to my periphery somewhere, I don't mind doing a diagnostic block, maybe at my mental nerve or infraorbital or supratrochlear and all those things. And I don't mind what a medication available. But don't think that everything is RF oriented, everything surgery oriented, everything cryo. No, please not like that. Whatever tools are available, wherever you are, you can provide good relief, fine. In case patient gets recurrent pain, please send them to your next eye center. Please don't think that you just because you don't have RF machine, don't stop treating these patients. Please, this is my only plea from my side to everybody. That's all I can say. Please help everybody.
Thank you, sir. Point taken. Point taken. Thank you.
Yeah.
Thank you, Dr. Basavaraj. Nice case. I think we have explained it and we have sort of discussed it. So thank you, Dr. Basavaraj. Now, can I invite Dr. Sneha Shreyas? Dr. Sneha, if you're there, can you share your screen, please? Dr. Sneha Shreyas is MBBS and DA from Mysore Medical College. She did her DNB from Meenakshi Mission Hospital, Madurai. Presently, she is doing a one-year fellowship in Daradia. Dr. Sneha, you can start, please.
Sir, same problem I'm facing, not able to make it full screen.
You want me to share your slides?
1 second, sir. I'll try once.
Karthik, take over. Karthik, take over. No, nothing wrong. Some technical console. Don't worry. Don't worry. Don't worry.
Sir, or I'll share like this now. Is it visible, sir?
Yeah, we can
Okay.
see.
It's perfect. It's perfect. Please go ahead.
Okay, sir. Thank you for nice introduction, sir. I'm Dr. Sneha, right now 1-year fellow at Daradia Hospital. Coming to patient details, it was a 72-year-old male patient. He was a retired bank employee by occupation. His chief complaints being history of pain in the left side of the face since 1 year. Coming to history of presenting illness, he complained of history of pain on the left side of the face since 1 year. The site of pain being left eye region involving forehead and nose. Onset was gradual. He complained of sharp stabbing electric shock-like sensation. Duration of each episode used to last for 2 to 5 minutes. And the pain used to aggravate by blowing of air over the face, sometimes when he's sitting under the fan, and occasionally even with touching the face near the eye region. Pain was always unilateral in distribution, and pain was associated with sleep disturbance. He was taking tab Angxit 0.5 mg since last 6 months. No history of nausea, vomiting, photophobia. No history of watering or redness of eyes or nasal congestion. Coming to his past history, he gives history of herpes zoster ophthalmicus 1 year back. Patient gives history that he has developed pain in the left eye region, which followed by skin rash and vesicles. The lesions healed gradually over the period of 2 months, but his pain persisted even after the skin lesions were completely healed. He had consulted a physician and he was treated with acyclovir 800 mg TID for 7 days and 1 course of steroids, which was prednisolone 30 mg for 1 week, which was tapered and stopped, and tablet Ultraset TID for 10 days. For persistent pain, he consulted a neurologist 6 months back, and he was advised tablet oxcarbamazepine 300 mg TID and tablet gabapentin 300 mg BD and amitriptyline 25 mg HS. Patient was not compliant with any medication. He had not taken it continuously for 1 month because he had no significant reduction in pain. He was applying gabapentin ointment twice daily in the area of pain distribution, and he reported there was some reduction in pain, which he was not able to tell me how much percentage reduction. Coming to his medical history, he was a known case of hypertension. He was on tab losartan OD, no other comorbidities. His family history was not significant. His personal history being diet was mixed, appetite was normal, sleep was disturbed due to pain since last 6 months. His bowel and bladder habits were regular. Coming to his general physical examination, no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. His BMI was within normal limits. His pulse rate was 65 beats per minute regular. His blood pressure was 140 by 80 millimeters of mercury. Coming to examination of face, on inspection, slightly hyperpigmented scars were visible over the left side of the face, on forehead, eyes, and little over the left side of the nose. On palpation, allodynia was present over left side of forehead, eye, and left side of nose. Coming to systemic examination, cardiovascular system, heart sounds were heard, no murmurs. Respiratory system, normal breath sounds were heard. Abdomen was soft, non-tender, and no organomegaly. Coming to neurological examination, cranial nerves examination, olfactory, normal smell sensation. Optic nerve, pupils were normal and visual acuity was normal. Third, fourth, and sixth nerve, ocular movements were normal. Trigeminal nerve distribution, allodynia was present over the left eye, forehead, and the left side of the nose. Seventh nerve, facial symmetry was present, movements were normal. Vestibulocochlear nerve, hearing and balance was normal. Glossopharyngeal and vagus. Gag reflex was normal. 11 cranial nerve, shrugging of shoulders normal. Hypoglossal tongue movements were normal. His investigation, his complete blood count was within normal limits. Random blood sugar 110 milligrams per deciliter. His MRI brain was done with trigeminal neuralgia protocol, which was normal. Coming to diagnosis.
Thank you, Dr. Sneha. Nice case, nice presentation. Thank you. So the history suggests a 72-year-old male with left-sided facial pain. This seems to be more around the eyes, so I'm assuming this is more ophthalmic distribution of pain. And before I talked about differential diagnosis, there is a history of post-herpetic neuralgia. So for all practical purposes, since there is a strong history and the pattern seems to be fitting, do all the experts agree when I say this is a left-sided post-herpetic ophthalmicus, or is there a possibility of it being something else? Any of the experts would like to concur, not agree with me? 72-year-old male, left-sided facial pain, 1-year history, severe neuropathic pain around the left eye, history of herpes infection. Gaurav, do you agree that it's post-herpetic ophthalmicus?
Yes, it looks like.
Okay, so any possibility that this could be cluster headaches, migraine, any other type of facial pain? Kumar sir?
Yes, Karthik, this is the case, even though looks like of more of a post-herpetic ulcer, we would like to go for little more room for differential diagnosis. As you said, there may be, we have to rule out any atypical facial pain also to be ruled out. So for that, we can carry it out simple ESR or CRPs and other things can be useful. If it is anything like any infections or any atypical autoimmune disorders are there, that is also useful. But most of the times it looks like, clinically it looks like the history wise and the duration wise and the clinical presentation wise, the first diagnosis, even though we want to put as a DT, it should be the post-herpetic ophthalmic division involvement. So as a completion sake, we have to rule out the other possibilities, atypical facial pain, especially, which is more of presenting with ophthalmic neurodes.
Right, sir. So the point they're making is that the basic blood tests have to be done, the total count, differential count, ESR, CRP, and the vitamin markers, random blood sugar, renal function test, B12, D3, uric acid, calcium, that has to be done. Dr. Sneha said she has already done the MRI of the brain and she followed the trigeminal protocol, and there doesn't seem to be any superior cerebellar artery compression along the trigeminal root entry zone. So we have the likely diagnosis of post-herpetic ophthalmicus in a 72-year-old male, 1-year duration, typical neuropathic pain. She mentioned the word allodynia around the eyes. Now, can I invite Joshi sir and ask him, considering this diagnosis, I'm assuming we're not going to investigate further. What is this?
Karthik, you want to have opinion of other people also? I'll join you anyway because sometimes some variations also might come.
Right, Dr. Archana.
Just my request, personal request, Karthik.
Thank you, sir. Dr. Archana, is there any other possibility?
Yes, so there is no other possibility actually, but we have to rule out again cluster headache, diabetic neuropathy, which may, but this is classical case of post-herpetic neuralgia only. Yes, sir.
Dr. Asha, would, is there any other investigation you want, ma'am? I think you're muted. From that time, I'm not hearing you. Anybody else would like to do any other investigation before I ask Murli sir, how's the conservative management of post-herpetic ophthalmicus? Murli sir, everybody is agreeing that it's post-herpetic ophthalmicus.
Yeah, Karthik, I do agree, but question sometimes, like, of course, this is a reference which is there. And the question here is we have to understand PHN. PHN is post-neuralgia. It's a question of sensation is different from neuralgia, the pain. Question here is, Karthik, one thing we have to understand, even if you read the first textbook of payment from John Bonica, there's something called trigeminal cervical nucleus area. If you just look at the picture, you can make out that one mapping. If you just look at the whole trigeminal thing, whole goes cervical almost up to C4, C5, C6 also. The question here is this group of patients might present and all, not that everybody who gets herpetic zoster will get a pain, but some will get this kind of pain. Now, which are those that group we don't know. So sometimes it does become difficult about this group of patients. But I think pharmacologically we have to ensure that they get relief and all. But one thing is, Karthik, I would like to alert everybody, it takes at least 2 weeks as per the literature. I mean, it's not from my personal, 10 to 14 days to achieve blood levels where you can get the medication working or not working. It's a different story, but at least 10 to 14 days time should be given before you rule out, because you have to confirm. The question here is trigeminal, you talk vascular conflict. What do you talk about with respect to herpetic eruption? It's there, it's visible, and sometimes it's difficult also. Like we are all, at least I am a burnt complexion kind of thing, the papules and all those things. It's not visible and all those things. But at the end of the day, what I would like to say is, yes, this can happen, this can be there, but I still feel that we, in fact, one or two patients we had, we went medication, and one or two patients we did a trigeminal RF also. But I feel this group of patients, I think, requires a sphenoparatine as the first one rather than trigeminal is my thought, in case we exhausted with medications. And that includes, again, phenytoin. Question here is what we are talking about. If some patient of trigeminal neuralgia comes to emergency, what are you going to give? So-called phosphenytoin, right? As per recommendation. And what is phenytoin? Plain medication. What's wrong about it? Phenytoin is father of phosphenytoin. So question here is, I think somewhere is not a possibility, may not be available. What if we are looking at here, at the end of the day, any chronic patient or acute pain patient comes to here and you get a call, your job is to handle the pain. What you do, how you do, it's your call. These are the medication available, these are the information available. Do what you feel comfortable as per your competency, available skills. I think, Karthik, about this particular patient, even if it's there, before you go for trigeminal, I would have probably tried a sphenoparatine before I go for the trigeminal, because one thing is V1, it is there, I can go for trigeminal, but if medications do help, well, I don't think any intention at all. Over to you, Karthik. Thank you so much.
Thank you, sir. Thank you. Okay, see, the thing is, post-herpetic neuralgia, in principle, is a very difficult condition to treat in any part of the body. Now, typically what happens is, things that we know very well about post-herpetic is, first thing is patients who have had early antiviral, like patients who have had acyclovir or any of the antivirals, the early phase of herpes infections tend to do better. Patients who have had vaccinations for herpes tend to do better. So these are the two factors which reduce the incidence of post-herpetic neuralgia. So patients who have had vaccinations and patients who have early acyclovir or any of the antivirals. So when I say early, the first 72 hours of the onset of symptoms. So these patients tend to have less incidence of post-herpetic neuralgia. Second is, once these two, they do develop post-herpetic neuralgia, the graph, if you see, the graph starts and then about, let's say, 30 to 40% of patients with herpes infection may have post-infection pain, which would be something like a post-herpetic neuralgia. Now, the graph typically goes up at about, in terms of pain score and time, the graph goes up at the end of 3 months to 1 year to 2 years. So 3 months to 1 year is the maximum intensity of pain. And if you see the graph, when I say graph, it's pain versus time. The pain score after a period of time in majority of patients comes down to around 2 or 3 out of 10 after a period of, let's say, 2 to 3 years. And this graph does not come to zero, but majority of patients tend to have some pain for long duration. Only a small percentage of post-herpetic neuralgias tend to persist with significant pain beyond 5 years. So one thing that you can reassure these patients is, with time, the post-herpetic pain is likely to reduce. But having said that, post-herpetic pain in any part of the body is very, very, very difficult to treat. So it's not one of those conditions in which I will jump and do an intervention. Now I'm going to go and ask Gaurav here, in terms of pharmacology, what are the drugs that he would use and for conservative management of post-herpetic neuralgia?
Yes, the drugs which we are using in post-herpetic neuralgia, we are taking it as a case of neuropathic pain. So we have to cover the neuropathic entity, and we have to start with the according to the severity, according to the pain condition, according to the allodynian hyperalgesia, we have to make a combination of drugs. How severe is the pain? So we have to use multimodal approach. We have to use oral medications in form of one medication in either gabapentin or pregabalin. We have to start, and if there is a more burning sort of features, so then we can add some amitriptyline or nortriptyline. Other than gabapentin or pregabalin, duloxetine or other SNRI is also first line treatment among all the guidelines which is being used all over world. Similarly, we can use duloxetine, and we have these are the very important drugs or in our armamentarium, you can say. This patient, particularly this patient, has a allodynia features, and then this associated history is only hypertension. Suppose many times it is being seen that patient is suffering from diabetes or other autonomic nervous system, or immunity is going down, or cancer patients. These are the common presentation of the PHN patients, post-herpetic neuralgia. Old geriatric patient with debilitating condition, nutrition is very low. So we have to take care all the aspect. We have to educate the patient about the to maintaining the good nutrition, good amount of all the things other than the medication, good amount of water and other intakes, maintenance of good hygiene. These all are points. Then we can use the drugs which can topically being used. So topically we can use lignocaine. We can use there is a there can be a combination of lignocaine and antineuropathic medicine like gabapentin and capsaicin, and in our region we have a good combination with ketamine also. So these are the good combinations which can be tried, and it varies according to the patient to patient. So we have to choose wisely, and we have to make a basket or a combination of the drugs to suit the patient. Like in older patient, male patients, we cannot use TCA groups. We should switch to duloxetine. And sometimes some patient tolerate the different drugs. So we have to choose one or two anti-neuropathic medication. Then we have to increase the dose slowly, and we have to observe the effect as well as the side effect. Then individualize the treatment. That is the important, as Dr. Joshi already told, that we have to choose one class of drug at least for 2 weeks. Ideally, it should be 3 weeks. So if we want to change the drug, so we have to give the trial for at least 2 to 3 weeks. Thank you, Karthik.
Thank you, Gaurav. So essentially, what we are trying to emphasize here is, this is one of those conditions where if you jump and do an intervention, you're likely to burn your fingers. So interventional pain management, severe neuropathic pain, post-herpetic neuralgia, generally we don't get great results. So this is one of those conditions where, see, when I get a phone call in my pain clinic saying so-and-so is having so-and-so problem, can I send them over to you? I'll say, yes, you send them over. Whenever I hear these words, post-herpetics and things like that, so I say, okay, we'll see what's happening. So this is one of those conditions in which you don't want to jump and do an intervention. One thing that you want to know is the pattern of pain as time goes in post-herpetic neuralgia actually changes. So if, let's say, you're having a thoracic segment post-herpetic neuralgia, if you see this patient in the first 3 or 4 months, this patient is predominantly nociceptive. So you may think of something like in the thoracic segment, you can think of something like an intercostal nerve block or a paravertebral block or something like that. But with passage of time, this becomes more and more neuropathic and more chronic and difficult to treat. So once it becomes chronic, like let's say in the thoracic segment, you have to think more in terms of pulsed radio frequency of the dorsal root ganglion and stuff like that, and stimulators and stuff like that. So it becomes more complex to treat. Now, can I ask Kumar, sir, is there, there's a chat box question about the role of lignocaine patches in post-herpetic ophthalmicus. Do they have a role, Kumar, sir?
Yes, Gaurav has enumerated everything. Very few points he left out for me to enumerate. And see, this is the post-herpetic neuralgia. I see that the number one point is the role of intervention is very much limited. So I have some disturbance. Okay, the role of intervention is very much limited. You have to fully almost depend upon the pharmacological management. As we know, we have to start with the carbonides and with anti-cyclic antidepressants. And it may be added, definitely the lidocaine patches are going to be useful in these conditions with capsaicin also. Any neuropathic, peripheral neuropathic conditions, especially diabetic and post-herpetic neuralgia, especially in thoracic segment, these ointments are very much handy, and patches also very much useful. But coming to this ophthalmicus area, we have to, one more thing is the incidence of the post-herpetic neuralgia, less with, as you said, the early antiviral, vaccinated, and the patients on steroid. That also have the less incidence of post-herpetic neuralgia. So the role of lidocaine patches with capsaicin is one another choice. It's worth trying it. And the another thing is the post-herpetic neuralgia. A lot of receptors are involved in that. That's why the Gaurav mentioned something about the ketamine also, that NMDA receptor involvement and TRPV also involvement. So the one more thing is the Botox injections may be last one to try. I don't have the good results with that, but it is for completion sake I'm doing that. Another, again, since Karthik pointed out, anything if this resistant, the time goes on, definitely the patient will be better off with the pain. If anything resistant to the only one left out intervention is the pulse RF. I tried 2 or 3 cases. Now I'm not at all doing that. That also, that we don't have much results, especially with anything around the face. So one more thing is, I would like to do that if at all intervention. I may try some of the glycerol injection, but I'm hardly did 2 or 3 cases, so especially the alpha ophthalmicus areas. So as he said, if the patient comes, especially this kind of the complication, I definitely refer to one of my friends who were there around me, that rather than taking this challenge, because it is tough to case, and especially in the facial region to the post-herpetic. If thoracic region, so many options are there, we can do that. But facial, as far as we have to stick on to the pharmacological management as far as possible. The one thing is, I may try as a last resort as a oral steroid also. It may help sometimes.
Right, sir. Thank you. Can I ask Dr. Matthew Tong here? Is there anything else that we can do in other than conservative treatment? We will come to interventions in the sphenopalatines and the trigeminals. Is there any other angle to this post-herpetic ophthalmicus other than conservative treatment, Dr. Matthew Tong?
I think most of the modalities of treatment have been covered, and I haven't got much experience in beyond that. Thanks.
Thank you. Can I call Dr. Archana here and ask her? At this point of time, most of us feel that we should treat this patient conservatively as much as possible. We talked about various neuropathic pain medicine regimes. We talked about topical ointments. We talked about patches, lignocaine, and other stuff. Is there a role for any IV infusions here? Is that something that you would consider for post-herpetic ophthalmicus or anything else?
Yes, sir. So it's a neuropathic pain. We can go for lignocaine plus ketamine IV infusions. Means they are given generally started with 3 to 5 milligram per kg per hour lignocaine, and ketamine 0.5 milligram per kg, and they are given over 1 hour, and they are given over subsequent days. Means the patient is called every day to the OPD, and it has to be done under anesthesia. The cardiovascular monitoring, and it could help in this post-herpetic neuralgia.
So you're talking about lignocaine infusion or ketamine infusion, or both together?
Both together. Both together.
Right. Okay. So yeah, I do use lignocaine infusions or ketamine infusions, but usually I don't match. That's the recommendation. But I think pretty much we can try. That's fine. Any of the experts have any experience on scrambler therapy? One of the audience questions. Anybody have any experience in scrambler therapy? I know there are a lot of pain clinics in the US which have scramblers. Koreans have scramblers. So anybody have any experience with scrambler therapy? Dr. Matthew Tong, do you have any experience?
In AIMS Delhi, they have this machine. I don't know about the experience. Don't got the positive feedback.
So Dr. Senthil Prakash, we don't have too much experience in India for scrambler therapy, but I do know a lot of pain clinics in the US and Korea and stuff do have scrambler therapies. Personally, none of us have too much experience with scrambler therapy. Right. So we are left with the interventions. Anything else? Local infiltration, dry needling, Jaipur block, anybody? Anybody has any experience with dry needling, injections, local infiltration of lignocaine, anything else before I jump into interventions? Any of the experts have any experience in any of this?
Yes, local infiltration is quite familiar, and it's very much published. It was published. It was started by the dermatologist people. They have used it with the good success rate. You can decrease the amount of peripheral sensitization if you use it with the initial phase, and it can work.
Okay, so now that we have talked extensively about conservative treatment, can I ask Jadan sir here, in terms of if none of this is working, and we have tried conservative treatment, we have tried IV infusions and patches, and considering post-herpetic neuralgia and post-herpetic ophthalmicus in particular is very, very difficult to treat. In terms of interventions, what would be his first choice and how would he go about it? Okay, Jordan, are you there? Okay, can I pass on that question to Kumar sir?
Yes, this is the clear point to take home point is as far as we have to stick on to the conservative management. If conservative management fails within 2 to 3 years of the severe period of the post-herpetic neuralgia, we may think of one is the any facial pain, then we have to think of the typical and the atypical. The most of the other than trigeminal neuralgia comes under the atypical facial pain. The atypical facial pain or neuropathy, trigeminal neuropathy characters, again, the most important left out area to play around for is the sphenopalatine ganglion. So the sphenopalatine ganglion diagnostic block, maybe the first line I would like to do that. If it is having good pain relief, we can think of the longer version of the pain relief by doing some kind of the radiofrequency ablations. That is the first one. I want to do that if they're specific in these conditions. So second thing is the anything if disease fails, we have to go for trigeminal block. That is very keep it as a last one. I want to do that rather than the first. I want to stick on to the sphenopalatine ganglion block. That is the only possible choice left out is the sphenopalatine ganglion blockade.
The audience, somebody has asked about sympathetic block. Is there a role for a stellate here? Dr. Nandita has asked about sympathetic block. I'm assuming she's asking.
I don't think say anything role for the. That's why the sphenopalatine ganglion has the role in the block rather than the stellate. So the better to do that sphenopalatine. I don't think the stellate would be the better choice for this kind of the pain. Other than the especially the pain is restricted around the V1 division or ophthalmic division. Better to I'll stick on to the sphenopalatine rather than the. I don't think it will be useful for us to do that. It's not worth trying it. It's my point of view.
Thank you, sir. Gaurav, is there a role for any glycerol injections or balloon compressions, trigeminal balloon compression?
For this, I would say the balloon and glycerol. Glycerol, though, you can use, but balloon for only for this ophthalmic division, it should not be used. It's basically it's a ischemic demyelination. It's a compression therapy for the whole ganglion. So why we want to target which are not affected the segment? So we should target it. Our approach do not overdo the interventions. So we have to choose wisely. So I'm not in favor of that percutaneous balloon decompression.
Right, thank you. So I would like to request the audience to, if there is any doubts, I'm going to put it in the chat box. I'm going to ask it to all our experts here. So we'll be winding up in 5 to 10 minutes. So if there are any doubts, please put it up in the chat box. So before I summarize whatever finding the experts have asked, can I ask one more word from Dr. Muralidhar Joshi? Is there anything else you would like to add at this point, sir?
Karthik, nice discussion, right? I think the most actually enjoyable moment for the whole event was you and Dr. Sirish with his child, like all the time jumping around, like her father. It's nice. I'm really happy. But Karthik, let's see question. I think Karthik, I did speak about this when you connected the conference about in I think Chennai conference 2019 or 18. I don't remember no, I think 2015. Yeah, that's where I did all the fiasco. I know very well, and whatever thing and all. 2015, right, Karthik?
Yes, sir.
Yeah. So question I did speak about PHN. See, PHN, if you just look at about, even if you just look at there are three kinds of PHN which can happen. One PHN is like, for example, I wear a shirt like this, say, for example, like this. I feel a little discomfort, but manageable. I don't take the medication. But some of us might say, like, I can't wear the shirt and all those things. It hurts me. So some of us might go for so-called intervention with respect to the intercostal block or infiltration and all. But some of us might say it starts firing like this, it's there all the time. Then we go for DRG, because in the autopsies, it has been proven beyond doubt the virus sits in the DRG with a necrosis factor, and in the autopsy postmortem, wherever PHN patient were there, it is proven beyond doubt the virus is sitting there. Not virus, necrosed, half necrosed, or maybe 3/4 necrosed DRG. The question here is handling these group of patients depending on complaint slightly varies. Question here is, if they're comfortable, don't touch them. Be happy wherever they're, whatever they involve. It takes some time. So almost 90% people who get PHN or whatever herpetic neuralgia or eruptions, they don't get pain. So the other 10% people. In fact, I am in so-called pain field is because of my mother, because she had C5, C6 had herpetic eruption. And that was the time the local general practitioners were treating her with That time, diclofenac was not available, brufen and all those things. That was when I doing my post-graduation, that was in 1993. Then I realized I was reading nothing great about that. I was just reading about carbamazepine, which they were not prescribing and all. See, that time there's no mobile phone. It's HTTP phone call, right? You had to wait in the hostel and they wait for your turn and all those things. Then I realized, okay, there's some specialty where I can work on. So that's why I got into this one. And believe me, Karthik, that was 92, and now I'm fast 2022 also. She just passed away a couple of years back. Even now also, whenever she was getting stressed, stress means it could be my father had some small fever, or we had to travel tomorrow somewhere, or sometimes she was not well for joint pain. Still, she used to get the pain. And nearly almost 3-4 days, she did not bear the blow, or even blows, even wearing also, she used to get it cut because it is hurting. So, question, but this pain may not go for almost 3 decades. Please understand, you don't have to offer intervention. So there could be some kind of discomfort. Whenever you're under stress, the pain comes back. It's not psychological. I've seen many people, and I say like they say, when I get stressed, I take some carbamazepine or pregabalin, whatever they comfort of it, take for 2-3 weeks, and they become all right. So I never offered predominantly to any PHN patient any intervention, but as a part of hope, I said, in case medication do not work, we have this option. That assurance itself made them feel comfortable, Karthik. And I would like to say my mother was the best example. Because of her, I happened to become so-called one of the pain consultant in India. That's all I can say at Karthik. But no need for intervention, not to jump for the, not jump for the. Yes, restricting medication, what are available as applicable, we can try it. Over to you, Karthik. Thank you so much.
Thank you, Zed. Thank you. So, for the sake of the delegates who are listening, overwhelmingly, all the experts seems to agree that for post-herpetic neuralgia or post-herpetic ophthalmicus, once you confirm the diagnosis, the conservative management should be the approach. You have an option of trying neuropathic pain medication in varying doses. You have an option of trying transdermal lignocaine, local application of lignocaine, gabapentin, pregabalin, and if it is available, ketamine. You have an option of trying IV infusion of lignocaine or even IV infusion of ketamine. So all these are the options. And basically, to reassure these patients that majority of them, the pain score will come down with time. Majority of these patients settle down with time to reassure these patients. So in principle, interventions do not work that well in post-herpetic neuralgia and in post-herpetic ophthalmicus. So manage these patients conservatively is the overwhelming opinion of all the experts here. Having said that, if this patient's pain is very severe and you've confirmed the diagnosis and you're not at all able to manage with conservative treatment, you have an option of going for a diagnostic sphenopalatine ganglion block. And if it is working, maybe consider a sphenopalatine RF ablation. Now, there may also be a role for a trigeminal block, maybe a glycerol injection in this case. There is always a role for neuromodulation. So neuromodulation may be something that we may consider, especially if the sphenopalatine is positive. So if you are getting results with sphenopalatine diagnostic block, there is a role for neuromodulation. We have specific neuromodulation techniques for sphenopalatine alone. So these are the various options. So at this point of time, I would like to congratulate Sneha and Basavaraj. Excellent case presentation.
Karthik, before you conclude, because it's important for us, because students are presenting, I just want a small word of advice to them. Please use as pharmacology combination. Don't use the company name. Is one thing as presentation. It's good for all of you. Is what I'm trying to say. Nothing wrong, nothing not wrong. But question here is it helps you in the long run. Not anything wrong you did. And second thing also, Karthik, I found we had one combination ketamine with amitriptyline. I don't take the name of the company because it's not right. But it was working very well for neuropathic pain for regional area and all. but subsequent people started using it like a toothpaste. Ketamine kick they're getting in the morning, so it's withdrawn. And about other ointments, I don't know much. I did try for things, but only for students, for Basaraj and also Sneha, is not that anything wrong about it, but for small advice is please avoid using the company names. Use the pharmacological, like not as Angsit, not as some company name and all. Nothing wrong about it, but it happens. We've done much more mistakes. We've done small mistakes. Over to you, Karthik. Thank you so much.
Sir, I have a doubt. Rather than doing sphenopalatine ganglion diagnostic block, why don't we do a supraorbital supratrochlear diagnostic block and do peripheral nerve like cryoablation, sir? Because this was only V1 distribution. If at all, conservative is for this patient.
Karthik is better person to answer that. Karthik, you go ahead. Karthik, go ahead. You go ahead. Go ahead.
So the answer is this is not a somatic type of pain. So it is a neuropathic type of pain. So that being the case, unlikely that we will expect great results from supraorbital sort of peripheral nerve block. So a lot of times what happens is I've had patients with postherpetic neuralgia. I've done the successful somatic nerve block, whether it's an intercostal or a trigeminal. The block has worked. A lot of times this patient will come back and say that part of the body is numb, but I'm still having pain. That's what I said in the beginning. Postherpetic, after a duration of about 6 months to 1 year, the pain becomes absolutely neuropathic. So if you do a somatic block, you won't get great results. That's why I was telling you, if you get in the thoracic segment, initially you should think about the intercostal, and after a while, when it becomes neuropathic, you should think in terms of a pulse radio frequency of the dorsal root ganglion. So after a while, postherpetics, even if you do a successful somatic nerve block, you may get numbness, but these patients will still have pain. So not likely that you may get good result with supraorbital. Probably a better way to go would be the trial sphenopalatine and proceed further.
Thank you. Baclofen, sir? Can we prescribe baclofen to this patient?
You can try.
Okay. Thank you.
Any of the other experts would like to contribute anything else before we wind up? Is there anything else you would like to add on to the discussion? Or any of the other senior members, junior members in the audience? Is there any other doubt or anything else you would like to contribute?
Sir, there was, when I was a fellow at Daradia, there was a patient with similar case presentation, this trigeminal neuralgia patient who had repeated RF. So that time, sir had done dry needling for her. Dry needling, and he was also publishing the result. So it is helpful to some extent in trigeminal neuralgia as well. Dry needling.
Probably personally, I don't have too much experience in dry needling, so I'm not the expert in dry needling. If there is anybody else who's fond of dry needling?
Can you hear me? Can you hear me, sir?
Karthik, sir?
Yes, Dr. Sirish, I'll come to the, Dr. Sirish?
Yes, sir. I've been practicing pain for 2-3 years in Nepal, sir. And I have very bad experience with post-operatic trigeminal neuralgia. Initially, I started having a very good result with trigeminal neuralgia. So I was very confident that this radio frequency in the trigeminal ganglion or gasserine ganglion would work. And one day, one patient came with post-herpetic neuralgia in the V3 branch, and we went for trigeminal or radio frequency ablation. But to my bad luck, the results were very poor. And as the expert panelists like Muliti Dasar and as you have focused, being for a new pain physician, I would think twice or thrice before going to the trigeminal radio frequency for the post-herpetic neuralgia. But like Archana Nakar said, we do in Daradia, we go for dry needling. And I have found a better, not complete, but better pain control with dry needling rather than the radio frequency frequency alone, sir. So pharmacotherapy along with dry needling has shown a promising result, but like with radio frequency, it was a total disaster. So I wouldn't go for
So
radio
thank
frequency.
you. Thank you, Dr. Shirish. So at this point of time, even though the result seems to be encouraging, at this point of time, dry needling has not come as scientifically proven or is not there in any of the guidelines. So at this point of time, till we have sufficient evidence to put it in any of the guidelines, it is still considered experimental, but with time, we may have more evidence. So that's the current status. Anybody else would like to add anything else?
Can you hear me?
Yes, Dr. Asha, finally.
Yes. Actually, I didn't know what was wrong with the setting because
Please go ahead.
times
Please
I
tell you.
tried to speak, but I couldn't. Yeah, I agree with Shri sir also and Archana because the dry needling works, sir. I was working with Vas madam, Lakshmi Vas madam. That time in trigeminal neuralgia, she had done submandibular, means peripheral block, submandibular and maxillary nerve block, and after that she had done dry needling. 4-5 sessions, and the patient got quite good results, sir. And one more thing I want to mention is I had one patient 6 to 7 years ago, female patient having herpes zoster involving the ophthalmic division. So I tried to manage her conservatively. She was very poor and she was a housemaid. So I tried to manage her conservatively for 1.5 years to 2 years. But ultimately, like she stopped the pharmacotherapy also because she was not able to afford the treatment. So once she came and then she cried, and also I had tried stellate ganglion blocker for her, and it gave.
I think we lost Dr. Asha again. So yes, probably if the spinopalatine does not work, there may be a role for stellate after we try the spinopalatine. So that may be
Avoid more investment.
that may be plan C. I think we are. I think Dr.
Can you hear
Asha.
us?
No, you are coming on and off, madam. So thank you. So if there is anything else, anybody else would like to add, or thank you, Asha, madam. I think your internet is not great.
Karthik, just one final one for all the beginners holding RF trigeminal. Just this suggestion. See, medial to lateral, you have got ophthalmic, maxillary, mandibular. But many people, I see, like they think once you enter foramen oval, the lesion is done. It's not like that. Depends on which division are you attending, because it's clear-cutly delineated about this whole thing is medial to lateral, ophthalmic, maxillary, mandible, and sometimes one nerve might be more thicker than the other nerve. So don't get disheartened about that one. For example, mandible might be much more thicker than maxillary. The long term, like it might be having gone through a lot of pain and all those things, whatever, it will thinner than mandibular. So you will not get maxillary. So what I'm trying to say is, whatever procedure you are doing, please try to understand why you are doing it. If you did not get result because you are there also still in the result means, please understand what was the reason. Were you there at the right place, right location, and right energy? If you understand this one, you will never get into a problem. Over to Karthik. Thank you so much.
Thank you, sir. So it was wonderful having Dr. Muralidhar Joshi, Dr. Matthew Tong, Dr. Archana, Dr. Shirish, Dr. Gaurav, Dr. Asha, Dr. G.K. Kumar. So thank you all to the specialists who joined us. Special word of congratulations to Dr. Basavaraj Kanti and Dr. Sneha Shreyas. Both of you did an excellent job in presenting the case. So congratulations.
Thank you for the opportunity.
Thank you, sir. Thank you for opportunity.
Keep up the good job, guys.
Thank
And so thank you all for the delegates. So on behalf of Daradia, so thank you for joining us today. So it was nice having you all here. I hope you had some useful points to take home after the discussion. So thank you all. So we will meet again next week or something like that. So we'll announce the schedule soon. So thank you very much. Good night.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.